Welcome, everybody. My name is Alec Murray. I'm the Associate Improvement Advisor in the iHub within Healthcare Improvement Scotland. And we are delighted to be able to welcome you to the first in a series of WebExes that's being coordinated through the Neighbourhood Care Programme in Healthcare Improvement Scotland, but delivered by our partners Buurtzorg, Britain and Ireland. So in the room with me is my colleague Sarah Turner.
Hi everyone.
And we're delighted to invite Brendan Martin from Public World, who will be presenting the main part of today's session.
Okay, thank you, Alec. Alec, can you still hear me, everybody?
Yes, we'll just pass the ball over to you in just a second, Brendan.
Yes, but just a second. I don't know how to move between the slides. Can you advise me on that?
Sure. We'll pass control over to you in just a second.
I've had trouble getting online with the WebEx. I'm on the phone now. So can you advise me what to do so we can get started?
Do you have you signed on at all on the WebEx, or would you like us to control the slides on our side?
Yes, I'd prefer you to do that, please.
Grand. If you just say next slide, we'll pass it on from our end.
Perfect, thanks.
So at the moment we've got a slide up that shows you the programme of webinars. There's 6 in total. So we wanted to provide support and information to the participating pilot health and social care organisations, but also conscious that there's actually some sites out there that are testing similar models of neighbourhood care. So we want to be able to join and share with everybody. The series will be recorded and the link shared afterwards, but the rest of the series we're going to save on a Knowledge Hub website that we're currently developing, and we'll share that link with you later on as well. So saying that, if you'd like to receive regular diary invites to these, please send us an email to the Healthcare Improvement Scotland Living Well team on that email address that you see on the screen there. So before we hand over to Brendan, we would just like to test something new. We would like you to, in a couple of minutes, you will see a slide. We would like you to say where you're calling from within Scotland. There's a map of Scotland up on the screen there, but also the national partners who help us deliver the Neighbourhood Care Programme, the iHub, Scottish Government, Healthcare Improvement Scotland, Buurtzorg, Cornerstone, SSSC and the Care Inspectorate. In a moment time, we'll flip over the screen to a whiteboard. If you click on that cursor that's shown there with the green arrows, you'll be able to then click on the map where you're calling from. If you're not represented on the screen, just feel free to type in the chat box who you are and where you're calling from. So we'll give that a go. Hi, Rhiannon, it seems to be working really well. Hi, Chris.
Hi, Alec.
Hello, it's Sue here. I seem to have lost the cursor, but I'll see if I can find the chat box.
Great. So thanks everybody for that. If you are calling in from Scottish Government, because we're conscious that the link's been shared with colleagues in Scottish Government, or anybody else, please pop in the chat box who you are, where you're from. It'd be great to see how wide these series of WebExes are spreading. So without further ado, we'll go over to Brendan. Brendan, if you can't see the slides, it is your first introduction screen. If you just let us know when to flick to the next screen, we'll do that for you. Over to you, Brendan.
Okay, thank you very much, Alec, and good morning, everybody, and I'm sorry about the inevitable technical hitches. So I'm very glad to be doing this first of a series of 6 webinars, and as you've seen, we'll run through not only starting with an introduction to Buurtzorg and what Buurtzorg's all about, and go through looking at some of the particular aspects of the challenges of introducing the model into an environment other than the one that Buurtzorg developed in, which was as a startup in the Dutch health and social care system, which is funded through health and social care insurance. And those are significant differences, although in our view, they're not fundamental obstacles to understanding the essential characteristics of what has made Buurtzorg succeed and enabling those characteristics to provide the kinds of successes and benefits that Buurtzorg has successfully achieved in the Netherlands. Next slide, please, and this should be the onion model. Is it the onion model you're seeing?
Yep.
Yep.
Yes, I can see that.
Okay, good. This is where we always start when we're talking about Buurtzorg, and those of you who've been to seminars or workshops that we've done before will know that. And the reason for that is that when Buurtzorg was established in 2007 in the Netherlands, the reason it was set up was that since its founders, Jos de Blok and 3 others, had qualified and begun practicing as community nurses many years earlier in the 80s, the system in the Netherlands, rather like our own, had become highly complex and, above all, had moved away from basing care around relationships between professionals and the people that they're looking after and the people important to the people that they're looking after, but rather had reduced care to tasks and time. And so it was a response in Buurtzorg to the trend characterized by new public management, which had been influential all over the world, and which, if you like, had turned care into sets of commodities and tasks rather than relationships. And so what the Buurtzorg founders wanted to do was go back, if you like, to basics and start again from the person needing support and simplify the systems around them. And the onion model represents really the fundamental of the Buurtzorg approach to care, which is to start with the person needing support, not only whatever challenges and problems they may have, but also who they are, what they want to achieve, what their aspirations are, what their capacities are, and what capacities may be revived or developed, and who can support them in their informal networks, their family, their neighbors, and so on around them. And the Buurtzorg team works to support the client and with the cooperation and the participation of their informal networks to remain as healthy as possible for as long as possible at home. And part of that role is also acting as a sort of care and case manager on behalf of the person at the center. And that's where the outer ring of the onion model comes in, because the Buurtzorg team, and particularly the members of the team who are particularly close, particularly responsible for the care of each individual, also acts as a sort of a navigator and a coordinator to support the person needing support to enable their access successfully to other parts of the system. And this is a basis of care and an approach to care that, being based on relationships, being based on, as Buurtzorg nurses often say, first coffee, then care. In other words, first the person, and then thinking about what care is needed in a highly holistic way. And above all, enabling responses in short time, in real time indeed, to the changing aspirations and challenges of the person needing support. It's clear that this approach to care means there needs to be a lot of freedom and responsibility at the front line, rather than managers or anybody else telling professionals how to do their jobs. And that's why the organizational model, next slide please, is so important. Because the organizational model for Buurtzorg is to enable care to be provided by small neighborhood teams. Buurtzorg means neighborhood care, that's what it means in the Dutch. To enable care to be provided by small teams, up to 12 people, usually something like 7 to 8 full-time equivalents, who work together and who provide support to each other, but also challenge to each other in small teams. And this slide here shows that the care model is indeed working. Just this year, the equivalent of CQC in the Netherlands did the latest inspection of Buurtzorg, and Buurtzorg scored maximum score in every category. In addition, the next slide, please. Buurtzorg has proved capable of, if you like, as some put it, restoring the professionalism to nurses that had been undermined, and nurses and nurse assistants, because the Buurtzorg teams are composed of nurses and nurse assistants, restoring the professional approach that they want to be able to build those kinds of relationships. And not surprisingly, that's led to a very high levels of job satisfaction, as evidenced by the success that Buurtzorg's had in being Holland's Best Employer of the Year, as defined by surveys done of many, many employers around the country, and coming second the other 2 years. So we can see that very good quality of care and very high quality of working life as well. Now, none of that would be sustainable if Buurtzorg had not also shown that this approach to care, next slide please, wasn't capable of also achieving significant savings. And many are surprised that an approach to care that enables nurses to provide holistic care, which means often with the same client doing everything from perhaps changing a morphine drip, very high levels of clinical intervention, to providing basic personal care. This approach to holistic care, rather than having successive people coming through the door of people who are often vulnerable and may be confused by a succession of people coming into their homes, many people think, well, it's surprising that that can be more financially cost-effective, given that some of the tasks that are being done by very highly qualified nurses could instead be done by much lesser qualified and less well-paid care assistants. But what's Buurtzorg's success has shown is that this approach to holistic care, and with the focus on enabling self-management and better independent quality of life for the people being supported, leads to fewer hours of care being needed, not fewer hours of care, but fewer hours of professional input being required on average per client. And that's one source of high levels of financial efficiency in Buurtzorg. And the other is that because Buurtzorg teams are self-managed and supported by a small back office which provides administrative supports that are better done at a central level. That's things like managing payroll, making sure the insurance, making sure the invoices are sent to insurers, and so on. Things that need to be done at back office are done at back office, but things that are better done by the team itself, such as organizing rosters and organizing their own workspace, and that sort of thing, are done at team level. So the two sources of financial efficiency are those: the reduced number of hours of professional input required because of this approach to care, and the reduced overheads because of the organizational approach of self-managed teams with a highly lean and very highly effective and supportive back office and an IT system that works, because the teams themselves find it a useful IT system, and as a secondary effect of using it effectively, it provides a high level of good management information to the back office. So it's because of, next slide please, it's because of those successes in care, in better jobs and job satisfaction, happy staff if you like, and in financial efficiency, that Buurtzorg was able to grow extremely rapidly from its startup in 2007 to, at the present time, around 950 teams with more than 10,000 nurses and nurse assistants in total in them. And this, as I say, is done through small neighborhood teams, up to 12 in each team, and the reason for that is that beyond 12, it becomes difficult to self-manage. They are supported by the small back office. They also have access to 20 regional coaches, and they work in accordance with a framework that is a simple set of standards of providing great care, providing a good working environment, and doing it in a financially efficient way, instead of a large body of rules and procedures and policies. The basic idea is Buurtzorg sets out the general framework of how the teams need to work, and the teams as professionals work out for themselves how to do it, but they all use the regional coaches. That's obligatory. There are certain standards about how care is provided. For example, the teams need to be available 24/7 in one way or another. That means that somebody has the phone at all times, overnight and at weekends. It doesn't mean that everybody has to work and be available 24/7, but it means the teams have to organize that. They have to build their own rosters around the particular needs of clients, and of course taking into account the different circumstances of members of the team. One of the other aspects of the framework is that they're required to see that they spend 61% of their time on average in client-facing situations, which is billable time, so that, because otherwise Buurtzorg itself would not be financially efficient. So there's a framework of ground rules in, if you like, 3 categories: great care, great working lives, and financial efficiency. And the teams work out for themselves how to operate within that context. Next slide, please. I'm just going to have to pause for a second. I've had technical difficulties this morning, which is extremely bad luck. Would you advise me what this next slide says?
Lessons of experience in NHS. Okay. Great care, great jobs, great support.
Okay, thank you very much. Up to in Public World and now operating as Buurtzorg Britain and Ireland, has been working in partnership with Buurtzorg now for the last 2 or 3 years, and we've now supported the development of teams and supporting organisational change in the NHS and local government organisations concerned, to enable them to support their teams as effectively as possible. And what we've discovered, perhaps not surprisingly, is that it's possible in the test and learn or pilot teams, if you prefer, but we prefer to call these projects test and learn, because we think that that's exactly what they're trying to do, not test whether this approach to care, which is summed up by Buurtzorg as humanity above bureaucracy, works, but to see what we need to do differently in various different contexts in Britain to enable it to work here, which means that, you know, the lessons that we need to learn in Britain and in different parts of Britain and in different contexts, whether in health and social care, and so on, we're building up a body of knowledge. But in general, what we've learned is that when professionals at the front line are enabled to work in this way, the quality of the care they provide is excellent and indeed improved. And one of the good things about the evaluation that was done of the early teams at Guides and St Thomas's Foundation Trust in London was that the evaluators looked not only at the experience of the people receiving care from the neighbourhood care team, as it's called there, but also at the rest of the community nursing service, and they found that there was general satisfaction, quite a high level of satisfaction with the general community nursing service, but a higher level of satisfaction from Buurtzorg, from the neighbourhood care team operating in the Buurtzorg way. And that was very interesting, because it's not as if they were comparing good with bad, they were comparing good with better, and that was very encouraging. In addition, the teams themselves in their interviews expressed high levels of satisfaction. But, next slide please, and this is the slide with quotes from the evaluators, yes?
Yep, organisational change.
Yeah, thank you. However, there was also some frustration on the part of the frontline teams that although they were they were more satisfied with their working life and wanted to continue to work in this way, their organizations were finding it quite difficult to adjust quickly and fully to the challenges of enabling them to work in this way, to providing the supports that are needed. And I think it's to the credit of Guy's and St Thomas's that the evaluation enabled the frontline staff to speak so candidly about that. And we know from evidence all over Britain that this is by no means a unique challenge to Guy's and Tommy's. Indeed, it's a challenge everywhere, because what this way of working involves is not just enabling a few teams to set up and work in a different way within the same kind of organizational structures and organizational mindsets that exist in their organizations, but actually it requires quite fundamental changes to the way in which the organization functions. And we call that organizational repurposing, away from organizational hierarchies that tell frontline teams or frontline staff what to do and how to do their jobs. Instead, creating an organizational environment that supports them and enables them to work as effectively as possible, and in which the back office sees its clients, even its customers, if you like, as the front line, just as the front line sees their clients as the people that they need to improve the lives of. So if you like, it's a bit like if you want your frontline staff to go to work each morning thinking, what can I do today to improve the lives of the people I'm looking after? You want your back office to go to work each day thinking, what can I do today to responsibly enable our frontline teams to do what they need to do. Next slide, please. And please tell me which one this is.
Can we do it in the NHS and public social care? It has an organisational map.
Yes. So what I've just been saying about organisational repurposing and the structure of organisations is represented by this graphic. On the left is a highly familiar, I'm sure, representation of the kind of organizational hierarchies that exist in typical, if you like, organizations. On the right is a representation of the more networked organization that Buurtzorg has developed, and that it supports other organizations to develop as the organizational structure and form and mindsets needed to enable the teams to do their jobs. And that, I think, is really proving to be the biggest challenge in public sector organizations in Britain, and one that it's not that we sympathize with the organizational leaders in those organizations about how they can tackle that challenge. But I think there's no getting away from the fact that that is the very big challenge that we face, because we've shown, I think, at a small scale at least, in the test and learn projects around Britain, that better care and better jobs can result, but the challenges of restructuring organizations, of the kind of organizational leadership mindsets that's required to really repurpose them, that's at a very early stage. Next slide, please. Which is this one, Alec, please.
From purpose to practice, it has Jos. We started working with different countries, and there's a picture of Jos de Blok.
Yes. And that goes back to the beginning, really. When we, as I said at the beginning of the webinar, when Jos and his friends and colleagues set up Buurtzorg, they did it with that in mind, to start again from the perspective of the person needing support, the patient, the client, or however that person is referred to, and to create conditions in which the professionals could provide those sorts of supports in a relationship-based way, and to simplify the systems around them. And that's really the challenge that we're facing. Next slide, please.
Be clear about your purpose and challenges of achieving it.
I think this is a link to a video of yours, isn't it?
Yes, it may be. We won't be able to play the video on the webinar, but we could certainly put that link in when we send out the link to this afterwards.
Oh, okay, sorry, I didn't realize that when we constructed the slides that it wouldn't be possible to show the link. But in that case, we can also provide 2 or 3 other links to videos that we think might be also useful for the participants in the webinar. So we can give you those links to share with all of the participants afterwards. Next slide, please.
That's great, thank you. Next slide is building the business case, 40% lower client costs.
So what I've tried to show in the seminar is that the way in which the care model, the organizational model, the way in which the care model requires the organizational model of local neighborhoods, self-organized teams, supported by coaches and a small but very lean back office and effective IT system. I haven't time today to go into much about the IT system, but we can provide lots of information about that as well. The IT system essentially serves the very simple, effective administrative supports that teams receive, but it also provides them with a classification system to enable them to make care assessments and care plans in a way that the nurses seem to think is useful to them, and also an intranet that enables them to share lots of knowledge and information amongst them. So that's what the IT does, and we can perhaps go into that in one of the future seminars. But the IT system is, of course, secondary, a tool like everything else. But the slide in front of you now is designed to show that, right, the care model in some ways leads to, that's not a timeline in this graphic, it's showing the different effects of the different aspects of the model. And it's certainly true that Buurtzorg, for example, employs a higher level of qualified staff than typical care organizations, and that, as I mentioned earlier, nurses are working to provide holistic care, everything from high levels of clinical intervention to basic personal care. But that, so in some ways, that increases costs because it can increase the unit labor costs. But enabling the teams to work in this way has an effect on reducing the number of professional hours of care required, enabling self-organized teams to cut out unnecessary hierarchy and unnecessary policy and procedures with a lean back office also reduces overhead costs. So if we're going to, the purpose of this slide is to just graphically represent that if we are going to create the strong argument for making the kinds of organizational changes in public sector organizations that are required to enable the kind of care and the kind of working lives that Buurtzorg has achieved, we are going to have to make the business case. And that means in really investing some effort and time and money up front in creating the organizational changes. And we are absolutely convinced, as this graphic shows, and as Buurtzorg's experience has shown, that over time, the financial savings will also be achieved, not over many, many years either. Buurtzorg was showing high levels of financial efficiency within 2 or 3 years. So this can be done, but it is a challenge in public sector organizations. Next slide, please.
Making things complicated isn't particularly hard.
But making things complicated.
That can be pretty complicated.
Yes, exactly. Well, I don't think I need to comment on that further. But that is indeed the challenge that we have managed, I think, in the British health and social care systems to create very high levels of complication and complexity. What Buurtzorg has shown is keeping it simple and keeping it small in terms of the small teams and back offices that have a very clear purpose and do everything that the teams need them to do, but nothing more, not intruding into the lives of the teams, but supporting the lives of the teams. Doing it that way simplifying means quite a complicated process of getting from a highly complex systems that we have now to the kinds of simplicity that we're going to need if we're going to be able to provide great care and great jobs in the way that Buurtzorg has shown that can be done. And I think that's the big challenge. That's where we are on our learning curve today in the various parts of Britain. I think that's the last slide, isn't it, Alec?
Yeah, that's the last slide, Brendan. Thank you very much for going through the WebEx. We've got a couple of questions that have come up in the chat box.
Okay.
So the first question, I think it relates to slide number 7, and it's from Chris Ruth, and it's, what do the red and green coloured countries represent on the global map of growth?
The red and green countries?
Yeah.
They represent...
Oh, sorry, Brendan.
Yeah, I'm unfortunately doing this blind at the moment, but let me see if I can solve the problem which I was unable to solve a little earlier.
The red is China, the Netherlands, Sweden, and the US of A, including Alaska.
Okay. I'll be honest, I don't know. Let me find out the answer to that, and we'll share the answer with you when we send out the links as well.
Okay. We've got another question from Jim, and he's asking, is there a risk that appreciated care workers may feel inferior to highly qualified nurses who the client may have a preference to, or that the highly qualified nurse may become disillusioned by doing the type of tasks normally performed by the appreciated care worker?
Yeah, I think it's a great question, because I think there is that risk, and I think indeed it's one of the challenges within the teams that I've noticed a number of the teams that we're supporting are grappling with. There's a real will. It's quite interesting. I was just working with a team yesterday in Kent, actually, and there's a new team, and there's a real will in that team for the nurses, which is composed of nurses and assistants. There's a real will to understand that everybody in the team brings with them life experience as well as professional qualifications. And I've noticed in Buurtzorg teams in the Netherlands that often the most highly qualified nurses benefit a very great deal from the least qualified but often highly experienced nurse assistants. So while there is that risk, and one of the issues I think we need to tackle in Britain and address openly and discuss is how nurses working in self-organised teams providing care in this way can make sure they keep their skill levels at the top of their license well up. And that's one of the reasons that Buurtzorg itself provides training budgets to each of the teams to make sure that individually and as a team they can make sure they keep up their training. But for example, but there is definitely a risk in the sense that if that issue is not consciously addressed in the teams and by their organisation as a whole, and discussed and solutions found to it, and the problems acknowledged and explored, then I think there is that risk. So like many of the other challenges of working in this way, it needs open discussion to see what the potential downsides are and find out ways and develop ways of avoiding them.
Thanks, Brendan. We've got a couple more questions, but we're conscious of your time, Brendan. We've got one from Sue and we've got one from Rhiannon. So Sue's question...
I'm fine on time. Don't worry about that.
Okay. So Sue's question is, having worked as a community worker, how do staff ensure they have the expertise and skills to link people to informal support, as these can change all the time?
Yes, and I think it's part. So I think I mentioned earlier that one part of the framework in Buurtzorg teams in the Netherlands is that 61% on time should be spent in client-facing situations. So what happens to the rest of the time? Well, that's sick leave and holidays and so on, teams meeting and looking after meeting with each other and doing intervision and so on. But one of the important things that teams do is to maintain their outreach and connections with their communities. There are some guidelines, for example, about where they should situate their offices to enable to be highly visible. And it's a normal part of the activity of Buurtzorg teams to go out and make connections and keep alive those connections with local voluntary organizations and so forth. So it's very much part of the normal activity of teams, and that's one of the reasons why there has to be enough time in the life of a team for that sort of work to be done. You could easily drive up client-facing time higher and higher and higher and think, well, this is very highly productive. But actually, in terms of the project, the purpose of building neighborhoods of care, and that's one of the, I mean, Buurtzorg, I think, has a dual meaning, neighborhood care. It's providing care at neighborhood level, but it's also setting out to build neighborhoods that are more effective at caring for themselves with professional support, but with effective cooperation between professionals and others. And that's a normal part. So that's something that teams need to be discussing regularly to see that they are keeping up their relationships with the rest of their communities.
Okay, we've got another question from Rhiannon. Is the employment of higher qualified staff a strategic aim of Buurtzorg, or has it resulted from local team recruitment outcomes?
It's a great question, Rhiannon. Thank you. It was a strategic intention from the start. The idea being that the teams that are composed of three categories, so three levels of qualification in the Netherlands: bachelor nurses, registered nurses, and nurse assistants, in roughly equal proportion, would be able to cover all of the various different supports that they needed to give to their clients. And as part of the general culture within Buurtzorg, the teams themselves replicate that balance generally in the way in which they recruit their own additional members. So it gives me a chance to also just mention that Buurtzorg teams have always started in one of two ways. A group of nurses gets together and says, or nurses and nurse assistants gets together and says, oh, we'd like to start a team and there isn't one here, and then they go through a brief process of induction and due diligence and so on. And if all that's successful, they become they become a Buurtzorg team. And the other way is that once teams get to 12 in number, they do need to divide. And that means that they can divide perhaps into two teams of 5 or 6 and then start to build up their numbers again. And all Buurtzorg teams recruit their own members, and they do so bearing in mind the needs of their neighborhood and the needs of the clients that they've got on their books, or that they anticipate may come on. So, for example, although all Buurtzorg nurses work as generalists, most teams try to ensure that there are also some specialists in the team that can act as the experts, if you like, and the advisors for the team about their areas of specialism, whether it be end-of-life care or perhaps the diabetes or whatever changing needs are in the community. So the strategic perspective that Buurtzorg had from the start about the proportionate composition of teams has been proved to be about right, as the teams themselves tend to replicate it in responding to the actual needs of their caseload and of the wider community around them.
Okay, thank you everyone. Just for the purpose of the recording, we're just going to stop it there, but we will share this recording afterwards, but future ones will be put on our Knowledge Hub website once it's up and running. Brendan, we do have a slide of the future dates on our screens at the moment. Do you want to just chat about them?
Well, as I said at the beginning, the webinar series as a whole, after today's introduction, and because it's been a bit messy, Sarah, maybe it's possible to do another recording if you want me to. I can do that. An unprecedented combination of IT problems in my normal working place today, so I do apologise for the raggedness. Over the 6th, the aim is to go into some detail now from about the different aspects of the Buurtzorg approach. So the next one we'll be looking, I can't see that slide, so correct me if I go wrong, Sarah. The next one will be looking at the care model itself and how teams develop their relationships with the people that they look after and the informal networks and the rest of the system around them. So that aspect of the care model. We'll then be going on to look in more detail at how self-management works in teams and further from there at the organizational challenges. Can you remind me of the names of the seminars, Sarah, because then I might have a bit more idea.
Yeah, so the next one's going to be on the Buurtzorg onion model. The third one will be on how self-managed teams work.
Yeah.
The fourth one will be developing a framework for self-management. The fifth one will be the role of the team coach. And the next one will be the organizational repurposing and what the biggest challenge is.
Great, thanks. And so I think what we'll try to do is those are the building blocks, if you like, of what makes Buurtzorg successful, from the care right through to the organizational repurposing, and not least the how you construct a framework that both provides cohesion in a whole organization and, if you like, defines the boundaries of the autonomy of the self-managed teams, but without constricting the autonomy of those teams. So designing that framework is a very important part of the transition to working in this way. And we're gradually building up quite a body of knowledge about how best that can be done, and that seminar will be looking at that. In the case of the role of the coach, that speaks for itself, and we'll be doing that with both input from a Buurtzorg coach and one of the coaches that's got experience in Britain, where some of the challenges are specific to Britain. The organizational repurposing one will be looking both in general at what has worked, so we will get some input there from Buurtzorg specialists who've worked in other Dutch organizations to help them transform from within, but also some of the granular detail that we've learned is important for the organizational repurposing is now specific to Britain, so we'll have inputs also from there. But the next one will look in more detail at how the onion model works with input from a Buurtzorg nurse herself, and then the third will look at how self-management works, looking at in particular, if you like, the core methodology of Buurtzorg teams, which is how to use the solution-driven method of interaction. And so we'll be doing an introduction to that methodology because it really is the foundation stone of the mindsets and organizational processes that Buurtzorg teams use.
Well, thank you very much, Brendan. I think you did remarkably well working blind, as you must be doing. Thank you very much for your time, and thank you very much, everybody else, for joining the WebEx. As Sarah said, they'll be recorded and they'll be put on our iHub or the Knowledge Hub sharing website, so please get in touch with the email address that you see on the screen if you'd like to be a member of that. We'll send this recording out to everybody who joined, and also we do have this room booked until 12:30, so if you are able to, if you'd like to, please stay on the line, because we're conscious that there's some questions that we didn't have time to answer today, but if there's other questions, please email them in to us. We'll collate them, get Brendan's replies and send them out also. But thank you very much.